We're excited to have a panel here on community health and liberation. I'll say a few words and then we'll turn it over to our panelists. So, community health and liberation are not words we seldom hear together. Our country's been told we have been the best healthcare in the world, when the reality is that we have the most expensive healthcare system and only moderate health outcomes, and only for a few. We also have one of the greatest health disparities in the country, right here in Cleveland. Life expectancy in one census tract in Cleveland is 23 years less than in a community just a few miles away in the exurbs. White supremacy and capitalism have shaped how healthcare is delivered, who gets treated, what's provided, who provides it, and where it takes place. Corporate interests close clinics and hospitals in urban communities where people live and build new state-of-the-art facilities in the exurbs where those in charge live and where many of the providers live. Beyond that, the system focuses on waiting until after people get ill before they're treated. We know from a public health perspective that prevention saves lives and is more cost-effective. The health industrial complex dictates the medical attention being funneled through a treatment system in which some get treated well, some struggle to have access, and some are denied health care altogether. Not only that, capitalism and white supremacy define even what we mean by health. We recently had some Maori leaders from what is the land known as New Zealand give a forum on indigenous knowledge, environments, and well-being. They pointed out that for the Maori, health is not a singular individual concept that is tied to one's physical condition alone. A person's well-being is the reflection of many dimensions, including physical, spiritual, family, mental dimensions. Well-being for the Maori is a reflection of the environment and how well the environment is cared for where people live. So liberation in community health means challenging not only who gets access to health care, but how health care is framed and delivered. We're encouraged by groups here in Cleveland like Birthing Beautiful Communities that are challenging those oppressive frameworks and systems and advocating for building a holistic approach to improving health and well-being from the ground up. So who has access to health care and the resources that promote health? The right to health care should not be something determined by politicians who are not experts in health and who deny access to people they don't represent. So today we are blessed to have three leaders who are challenging these oppressive systems and working toward liberation. I'm going to introduce them in the order they're going to speak, and then as we've done so far, we will have them each speak, give a 10-minute presentation or so, and then we'll turn it over to the audience for questions. First, we have Dana Langford, who's a certified nurse and midwife and serves as CEO, medical director, and co-founder of the Village of Healing Center. The Village of Healing Center opened its doors in early 2022 to provide Black women access to culturally sensitive care from the time a woman steps into the clinic and throughout the duration of their visit. The center is the first and only clinic for Black women in Cuyahoga County, and will serve as a venue for women in need to access gynecological, antepartum and postpartum care. Langford has committed her career to serving, educating, and empowering and advocating for Black women. Thank you for being here, Dana. Kenya Farrow is a writer, editor, and strategist whose work has long focused on public health and infectious disease with a focus on racial, gender, and economic justice. Kenya Farrow is a managing director of advocacy and organizing for Prep for All, an organization of community members, healthcare professionals, lawyers, and academics, all dedicated to increasing access to life-saving HIV medication. At Prep for All, Farrow has been working on fighting insurance companies on behalf of patients and advocating for a national PrEP program for the uninsured. He has been active in pursuing the Ohio Department of Health on responding to monkeypox outbreak in Ohio. Farrow is a featured columnist with the Ohio Capital Journal and serves on the board of the LGBT Center of Greater Cleveland. In addition to his political work, Kenyon is a prolific essayist and author. He's co-editor of the book Letters from Young Activists, Today's Rebels Speak Out. His work has also appeared in many anthologies and major publications. Farrow has been hailed for his work by numerous institutions, including Out Magazine's Out 100, the Roots 20 Black LGBT Movers and Shakers, and Black Entertainment Television, which designated him a modern Black history hero. Thank you, Kenyon, and thank you for coming back to Cleveland, to your roots. Jesse Hill is Associate Dean for Research and Faculty Development and Judge Ben C. Green Professor of Law at Case Western Reserve University School of Law. She joined the CWRU faculty in 2003 after practicing First Amendment and civil rights law with a firm at the Reproductive Freedom Project of the National ACLU. She joined the CWRU faculty after practicing First Amendment and civil rights laws with the firm of Berkman, Gordon, Murray, and Devan in Cleveland. Before entering private practice, Hill worked at the Reproductive Freedom Project of the National ACLU office in New York, litigating challenges to state law restrictions on reproduction rights. She also served as law clerk to the Honorable Karen Nelson Moore of the U.S. Court of Appeals for the 6th District. Jesse's teaching focus on constitutional law, civil rights, reproductive rights, and law and religion. Her scholarship has been published in a number of leading scholarly journals, and I know she's super busy right now on her work on reproductive rights. So thanks for taking time to be with us. So we'll hear from each of them. Let's give them a round of applause for joining us today. We'll hear from each of them, and then I'll come up and moderate some questions.
Good afternoon. My name is Dana Langford. I am the CEO and Medical Director of Village of Healing and the Village of Healing Center. I have practiced as a certified nurse midwife for about 13 years, probably a little longer. I actually, when he just said challenging oppressive systems, I'm like, is that what we do at Village of Healing? But I guess so. And we just never thought about it like that. We just thought about the fact that we were constantly hearing Black women and babies were dying, and we needed to do something about it, and we were tired of talking about it. So in 2019, we started Village of Healing and the Village of Healing itself in July of 2019. I had gone to Ghana, and I didn't realize what a life-changing experience it would actually be. Prior to going to Ghana, I was asked to sit on lots of committees around the city and in the county on infant and maternal mortality. And I was so excited because I thought this was a chance for me to actually make a difference in my community. I had just moved back to Cleveland. I love Cleveland. I'm born and raised here, but I've been gone for about 10 years almost. So I was like, yes, this is it. This is my time to make a difference. And I realized that we weren't being heard in these meetings, and we were actually asked to be tokens sitting in these meetings. And so it was completely against my spirit to be quiet, to be a token, and to just sit there and be the Black representative, but be constantly told that Black women were 3 to 4 times more likely to die due to childbirth complications. And that if you were over 30 with a bachelor's degree, you were actually 6 to 7 times more likely to die than a white woman with no high school diploma. And that just from living in Cleveland and Cuyahoga County, my baby was going to be 7 times more likely to die from being a Black baby than a white baby. And so to constantly sit and hear that with no action steps. And then when action steps are brought to the table by Black communities and Black organizations, they're given pennies on the dollar and compared to all of these large hospital systems in the city that obviously aren't making a difference because the numbers continue to grow. And so my partner and I, Tanisha Gaines, had recognized at that moment we were tokens, and we recognized that it wasn't a good feeling. And so we had to do something different, but we just quite couldn't figure out what that looked like, because we also grew up in a city that is the number 9 on the most segregated cities in this country. And so we knew there was racism here. We knew that there were the 3 largest hospital systems, and every time we came up with an idea, people would say, you can't challenge the hospital systems here. It's like the mafia, you can't challenge the hospital system. systems. So I took a trip to Ghana in 2019, and I visited the slave dungeons. And I remember at one point they put us where they had left the women slaves that they felt had misbehaved. And it was a dark room, very wet, and they actually closed it to allow us to truly feel. And it was in that moment that I heard my ancestors having a conversation with me that it was my obligation and it was my duty to go back and do something, and that I couldn't just let the numbers continue to happen. And so I had multiple conversations in that room. And I got back and I told Tanisha, we got to do something. So let's at least start with a community development organization. And so that was Village of Healing in July of 2019. The focus was we knew that the Black community had continued to place our health and our well-being in resources that really didn't care. We continued to depend on resources that just didn't know our community. And in that place, they kept us dependent on them. But we knew that we had everything that we needed inside of our own community, that all we had to do was get everybody together and we could heal ourselves and we could focus on our own healing. So we started with 2 community programs, and it was right when George Floyd was murdered, Breonna Taylor was murdered, and COVID was coming out. And again, we were constantly being told that Black people were more likely to die from COVID. And so we wanted to be able to give some type of mental health wellness and all of that. And so we started our Mother to Mother program, which focuses on moms who are currently going through maternal mental health complications. And it pairs them with other Black moms that are recovering from maternal mental health complications. And the goal was to have a conversation, to have a peer-to-peer support with someone that looks like you, someone with a similar lived experience, and to break down the stigma around mental health, to be able to tell somebody comfortably, I am not okay. And so that's what we wanted to start with our Mother to Mother program. They would decide what that relationship looked like. And they would decide how they wanted to move forward in that relationship. But it gave them the freedom, again, to be able to connect. And it gave them the freedom to be able to be vulnerable, especially as Black women. We knew there was this strong Black woman stereotype, but we wanted to let them know it was okay to say, I'm not okay. And so we started that Mother to Mother program. And from there, the CDC had just come out with their study to say that Black women, again, over the age of 30 with a bachelor's degree were actually 6 to 7 times more likely to die. And in all these meetings that we sat in, we noticed that the conversation was centered around poor Black women. And we felt like it was easier for white supremacy and for white people in Cleveland to put their arms around poor Black women, but they left professional Black women out of the conversation. And we knew ourselves, we were struggling. We knew, again, we had the same odds as these so quote unquote poor Black women, right? Our babies were still 4 to 7 times more likely to die, depending on the time period, depending on Cuyahoga County versus Cleveland. We were actually 6 to 7 times more likely to die. We were being unheard, and so we wanted to change the narrative in the conversation. So we started our professional Black women's group, which met twice a month with a therapist, and it allowed a safe space to just truly be authentic in situations where we knew we were going to work every single day in code switching, and not being allowed to be truly authentic in who we were. So it allowed us to be able to use the language we wanted, the ebonics we wanted, all of those things in this situation, and then to dissect what it really felt like to be professional Black and a woman and what that looked like. We knew we were at the center of racism. We knew that we should be at the center of the conversation because we were reporting to these jobs and these institutions every single day. But no, when the CDC came out with their study, I remember being at our hospital and they're like, well, why is that? Why would professional Black women be more likely to die? And I looked around the room and there was one of me and 12 of them. And I'm like, this is why. Let's have that conversation. And so we did our professional Black women's group. But from there, City Lab had come out with their study to say that Cleveland, Ohio was the worst place to live if you were a Black woman. And it followed with, you were second to last as far as healthcare. So at this point, we were exhausted with hearing you can't challenge the healthcare systems, because why not? The healthcare systems obviously don't care about Black women or Black babies. And so at this point, we knew it was time to start the Village of Healing Center. We knew at that point that studies were coming out to say if your provider looks like you, your chances at survival increase, your disparity decreases, your outcomes are better, your adherence is better. And so we said, we keep hearing, well, what does the data say in every single meeting we go to? Why can't we present them with the data, and from that present them with a clinic that has Black providers taking care of Black patients? And so we started the Village of Healing Center. And we started it, and since then we have gotten a lot of recognition from elected officials, from the media, from philanthropy, that have all noticed what the data says and have said that we strictly support the data. So in February of 2022, on February 14th, actually, we opened our doors to a Black healthcare center that is Black owned and focused on Black providers taking care of Black patients. And I don't know if you all understand how important that is, how great that is, because I was told multiple times I could never stand in front of a room and say I was opening a healthcare center for Black providers taking care of Black patients. I got called a racist. I got called being prejudiced, discriminatory. I was told it would never take off, it would never open, I would never be able to use those words. We even brought in a white grant writer to use the words for us to start, because we knew it would be easier coming from her than us. But now I get to stand in front of rooms, I get to be on TV, on the cover of the Plain Dealer, all of those places, and say, I have a Black-owned clinic with Black providers that take care of Black patients. But not only that, the aesthetics, the vibe, as my patients say, when you hit the door, you know you are in a safe space for Black women. From the colors in the clinic being red and yellow and bright and vibrant like my community, to every room in the clinic being named after a Black person in history that you rarely hear about, all the way down to the 3 exam rooms being named after Anarcha, Lucy, and Betsy, the 3 enslaved women that were tortured in the name of gynecology and never got credit, but their bodies were used in at least 30 unmedicated surgeries each in the name of gynecology. And we praise that white man and give him statues all over this country. And we don't even acknowledge the women whose bodies were tortured for that. All the way down to our pictures. We have a Black art gallery, all done by Black artists in the city of Cleveland. So that when Black women walk in there from the door to the exit, they know that this space is for them. And so right now we're focused on obstetrics and gynecology. I'm a certified nurse midwife that sees patients there. We offer centering pregnancy, which is group prenatal care, which has been shown, especially in urban communities, to decrease low birth weight infants, to decrease preterm labor. We work very closely with, as they said, Birthing Beautiful Communities. When you come in the door, you are automatically connected with a doula, and we are now focused on team-based care. That's something that you'll hear in a lot of the medical systems, but as a Black woman, when I walk into those systems, my team looks nothing like me and can relate to me at all. But the fact is that when you walk into the Village of Healing Center, that team-based care now looks like you and might even live around the corner from you. So you get a nurse midwife that's Black, you get a doula that's Black, and we're there for your whole entire family, from the father of the baby to the patient, and you're all included in that care. We also have now added mental health to our services. And we recognized that there was a need for mental health, but I don't even think that I recognized as much how much of a need there was. She started at the end of July. A typical mental health caseload looks like 30 to 35 patients. From July to last week, because she emails me every week her caseload, she is at 53 patients. So I've had to stop her from seeing new patients. So we're now looking for a new mental health provider. But that's how much the need is in the community for a provider that looks like you. And so while we were constantly told this would never work and we would never be able to say it, The community has shown us that this does work, that we can say it, and that they will support it. And so I leave you, and I thank you all so much for having me here. And just know, and I'm sure we'll have this conversation, and I'm sure the gentleman after me, definitely Mr. Farrell, will bring it up. We need your support, that we are out here challenging these systems, but we need your support to do so. Nobody will listen to us if we just out here banging on doors as our lonesome selves. But the fact is that we need everyone's support so that they know we tired. We are tired. We are exhausted. I don't want to hear any more about my baby dying. I just sat through another presentation where they said in 2020, Black babies only made up 34% of the births in Cleveland, Ohio, and Cuyahoga County, but they represented 73% of the deaths. I shouldn't have to sit in a room and listen to that all the time. And so let's do something about it, and let's do something about it as a community.
Thank you so much. So I'm going to be using a slide deck, so I'm just waiting for those to appear. While we wait on those, I'll just briefly say, just listening to your story, perfect, they're there. I have a very good friend of mine who I went to Ohio Wesleyan University with, Black woman, father actually teaches at Ohio Wesleyan University, Black World Studies and Religion. She lives in Baltimore. She's a registered nurse, master's degree in nursing, certified midwife, master's in public health. And she had to find a provider in Montgomery County, which is closer to DC in Maryland, because after going to several different OBGYNs in Baltimore, she was spoken to like she was stupid, to quote her, so many times. And even after she told them, I'm actually a certified midwife and I have a master's in nursing and in public health, and still was disrespected to such a degree that she couldn't even have her child in Baltimore County. And so thank you for your work. It's very important here, and it's important in so many places around the country. So I'm going to shift and talk a little bit about public health. My talk is called Beyond Tuskegee, Public Health and Racial Justice. Essentially the reason for my talk is, so I've been working in primarily in HIV prevention, but I've also worked on viral hepatitis, tuberculosis, COVID-19, and monkeypox recently. And what's been interesting is, so over the last couple of years, because of the COVID-19 pandemic, so much more focus happened to kind of talk about the issues of medical mistrust that created sort of vaccine hesitancy, and even kind of the belief in certain kinds of medical conspiracy theories in the Black community, when it was clear that after we sort of developed the vaccines for COVID, in that sort of short record period of time, the folks weren't necessarily ready to take them right away, right? And so I had already been writing about sort of medical mistrust and conspiracy theories that I was seeing, particularly targeting Black folks on social media, really about HIV primarily, that then I started to get phone calls when I, for a while, couldn't get anybody to pay attention that, there's all these like bots and these weird things targeting Black people about these like fake cures and, these other sort of issues around the HIV epidemic online, that then all of a sudden became sort of national conversation around COVID. And so oftentimes, as we've kind of heard, so we'll talk about the Tuskegee syphilis experiment in particular, and its relationship to medical mistrust and conspiracy theories, talk about medical mistrust, how it impacts community response and uptake of public health information and guidance. Discuss the resurgence of medical research, conspiracy theories, and HIV and COVID-19, and then I'll talk about some strategies for the workforce to play to address medical mistrust and increase engagement in care. So a couple things about the Tuskegee syphilis study, and I use this because in so many, if you remember, in COVID-19, so much of the sort of public discussion was about, oh, this is why sort of African Americans are hesitant around the COVID-19 vaccine, et cetera. And that is true to a certain extent, and it still remains when I do this work and kind of talk to and present to a lot of Black audiences. The Tuskegee syphilis study kind of gets referenced a lot, right? So I'm going to talk about the study, talk about what happened, and then talk about, sort of what it means in terms of like this issue of medical mistrust. So syphilis was identified first in 1905, right? Just to give us a little timeline. We had a diagnostic test for syphilis in 1907. And in 1926, African Americans had a 36% prevalence rate of syphilis, right? Which is extremely high. The disease was believed, now see, this was some of the like kind of white science community at the time, believed that the disease sort of behaved differently in Black bodies than white bodies. And so that was the initial sort of thrust of why they wanted to do this study, which was launched in 1926. And initially lost funding, but then had kind of relaunched again and officially sort of launched again in 1932. So to walk through the specifics of the study, right? So launched in 1932, and it included about 300 Black men in the Tuskegee, Alabama, the town of Tuskegee, and in that county. And what they did was essentially knew that those men had syphilis, and then they kind of watched the disease progression, right, without treating them for syphilis for many, many years. So in 1936, the major paper on the experiment was published. And to also debunk some of the myths, the study was criticized by Black people, by Black physicians from the very beginning, right? But they just weren't listened to for many years. And in 1940, men in the study were denied entry into the military in order to prevent the treatment of syphilis, right? Because if they had joined the military, they would have actually been treated. In 1945, penicillin was widely available as treatment for syphilis, right, to cure syphilis. And yet it was not given to men in that county. In fact, they were actively, now this is of course before the internet and before people could search in Google. So they only had the information that was given to them by, the doctors and the people sort of running the study in town. And so they were actively dissuaded from knowing that there was a cure and having access to it. And so this went on for another 30 years. So it wasn't until 1972 when some of the first sort of major news articles were published about the study condemning it that the study was subsequently terminated. Right, so here's from the New York Times on the right-hand side, and then here from the Black Panther Party newspaper in 1972, right? Just so you see how the issue was discussed. So why was the Tuskegee syphilis study a particular kind of travesty? So first of all, it's often referenced as a sort of like example of like hyper experimentation on Black bodies, right? And actually, in a way, the opposite was true. The sort of biggest travesty of Tuskegee were two things. One was that they did not do informed consent to enter the study, right? Which is now legally what you have to do, and a lot of laws and infrastructure that was set into place. Like if you're a grad student here, you deal with your IRB, your institutional review board here. Those type of things were all established post the Tuskegee syphilis study in the 1970s and 1980s in order to protect people who were, participants in research studies. So they were not given informed consent. And then also that the government specifically withheld a cure from them for 30 years, right? Which, the penicillin, the antibiotic. So as opposed to the idea that it was an issue that they were sort of like, given some kind of drug or sort of hyper experimented on, they actually were not given anything, right? When a cure was known. And so I often use this when I talk to Black folks in a lot of conversations and trainings I was doing around COVID-19 when this would come up, was to say to people, look, if we're going to talk about the Tuskegee syphilis study, then the truth of it is that actually it wasn't that they were given something that they didn't need, or that was poison, or they were guinea pigs in that sense, that there was a known treatment that they could have gotten and that they were barred from getting. And so when we talk about disparities often in healthcare, public health, et cetera, more often than not is Black people not getting the care they deserve more than it is that they are somehow being kind of hyper experimented on in most cases, right? And so if we reframe sort of how we think about the healthcare institutions and infrastructure, it is those issues about actually not getting the kind of care that you deserve, as opposed to being given things that you generally don't need in most senses, right? So even the Black Panther Party, not only established like the healthcare clinics, which has been largely written about, but what a lot of people don't know is that they also advocated for federal funding for sickle cell research, right? Which they won, right? The Nixon administration actually created the first like sort of federal funding through the National Institutes of Health to start studying sickle cell, right? Some people often reference Harriet Washington's book, which I love, Medical Apartheid, when they also want to sort of talk about reasons for medical mistrust. But even Harriet Washington, is still a proponent of like why Black people need to participate in clinical trials, right? Or why, treatments are still necessary for Black people, as opposed to like, rejecting them all, despite the histories of violence that we see. So as I mentioned before, just some of the laws that were created to protect folks after Tuskegee. But one of the things I often talk to people about too is that the Tuskegee syphilis study still has far-reaching implications even now. So this was a story from 2015 about the sort of last Ebola outbreak, right, that happened. And even in Africa, right, folks were reticent to participate in trials for a new treatment for Ebola at the time because of the Tuskegee syphilis study. They did not trust the U.S. government, USAID, and some of the federal agencies that do global health infrastructure work because they knew about Tuskegee, right? And it shows up in this article. So it just has far-ranging implications. So one of the things that I often tell people too, when we talk about Tuskegee, and in my work, specifically working in HIV field, if the Tuskegee syphilis study ended in 1972, HIV enters our public consciousness in 1981. That's only 9 years. So it should be no surprise that when HIV enters like the sort of public consciousness in the US, that we would see the rollover and the impact of the Tuskegee syphilis study in terms of how people view HIV, the different conspiracy theories about how HIV was, man-made or population control and all the things that we know we didn't heard in the hood. Like, so, and even now when I travel around the country and I'm in Lyfts and in Ubers or whatever, and I talk to Black folks about the work I do, they always are very curious about HIV and want to know things. And when I talk to them about, what's available for treatment now, and the treatments are like really good, or that, we have a prevention medication. If you take one pill a day, it'll prevent you from contracting HIV, et cetera. And people say, well, don't you think that they got the cure and they're not giving it to us because there's more money in the treatment than the cure? And I understand the thinking behind that, but there's a lot of money in cures if you look at Gilead Sciences and how much money they've made off the Hep C cure, but that's another story. So there's a lot of money in cures. But to say, just some research showing that the impact of HIV conspiracy beliefs and African Americans, a substantial, in this particular study from 2019, shows substantial percentages of Black folks agree that HIV is man-made and the government is withholding the cure. HIV conspiracy beliefs and HIV risk were both associated with a higher testing likelihood. An association of HIV conspiracy beliefs and HIV testing were significantly mediated by individual level risk, et cetera. So what's interesting in this case is that in the case of HIV, for a lot of people, some of the conspiracy beliefs actually made people get tested more, right, than not. Even if they didn't trust, the public health system in certain cases. one of the things that sort of I get the most, right? So this happens in my DMs and Facebook groups I moderate, et cetera, organizations that I've worked at, is a lot of like, and this is happening through a lot of sort of bots and the kind of conversations about, most of your people maybe have heard of Dr. Sebi. I won't get into a lot of detail here. I'll just say one thing that I think that, you know, a lot of people will sort of swear by his different sort of diets, et cetera. But then there's a bunch of, which of course, like eating a plant-based diet, et cetera, will help you in a lot of health, you know, around a lot of health conditions, but it will not cure a range of infectious diseases, including HIV, right? But that is kind of a myth that continues to sort of float out there. In 2020 or 2019, I wrote this article because after Nipsey Hussle was killed, there was a lot of like chatter on the internet that he was murdered because he was making a documentary about Dr. Sebi, and that was, the whole sort of story behind like why he was murdered, and so, use that to sort of like talk about those sort of issues. But we see these things again kind of come up in COVID-19. So we see similar kinds of conspiracy theories in the early part of the epidemic. What's been tricky about the COVID response is that we've seen those things kind of emerge mostly in Black communities around Tuskegee, Henrietta Lacks, around real histories of racial violence through public health and healthcare and biomedical research. But we've also seen those kind of like emerge in like, sort of white, nationalist, kind of MAGA, conspiracy theories too, right? But having different sort of like, roots. In the process, right? So some of it was around, the Trump administration sort of first denial about COVID, and then in the confusing public health guidance that was coming out, claiming these different drugs would treat COVID that they wouldn't, et cetera, right? All creating a range of confusion around the virus and around vaccines. To turn to Ohio a little bit, so some of the impacts that like some of that stuff has had here, right? So just looking, I pulled this chart and it shows to this present day, right? The chart goes from the beginning of vaccine availability in December 2020 to, I think, October 27th. And still only half of African Americans in Cuyahoga County have a COVID-19 vaccine, at least one shot, right? Compared to 70% or more than 70% of white individuals, right? We look at the range of different sort of health disparities here in the county, and whether you're talking about asthma, diabetes, high blood pressure, HIV, et cetera, the same sort of neighborhoods and the same zip codes, southeast side, mostly Black, are where the largest parts of like this disparity exists, right? And it was referenced, but I'm just going to go there, right? So the Cleveland Clinic, right, which we are currently sitting right next to, has been ranked several years in a row with, getting the largest sort of tax breaks from a hospital in any city in the country, but ranking dead last when you compare those tax breaks to the community benefit that they provide in communities, right? And so, this also has an impact on your work, you're working on a lot of things that we're talking about here, right? In terms of how, hospitals, and that's one of the things I sort of tell people too, is that and there's research that also bears out when you look at sort of how Black folks who hold various kinds of conspiracy theories about HIV or other health conditions, it's actually the sort of correlates to that are actually more people who are actually educated. So typically people who are college educated and who know about these various histories of Tuskegee or Henrietta Lacks, et cetera, are more likely to hold various kinds of conspiracy beliefs about health issues. And then secondly, more than not, though, when you look across socioeconomics in the Black community, people who have actually had recent incidents of racial discrimination in healthcare settings means that they're more likely to also distrust those institutions, right? So, in closing, what do we got to do? So one, I think that we need to do more work to demystify public health clinical research, and healthcare systems, right? Because I think sometimes we lump things all together, and they're actually they relate to one another, but they're different. And I think the more we sort of explain and talk about, I think a lot of that kind of ended up happening in COVID because it just was more focused on how, research works and how it happens, how, public health happens, et cetera. I think we have to reframe like treatment and research, access issues as a racial justice issue. Whenever I talk to Black folks about like the disparities in terms of people being able to actually access, whether it's vaccines, treatments, medical care, et cetera, that they get, right? And so we think about, just shifting to sort of talk about like these things as things that you actually deserve. And when you can't get them, right, people become more interested in them than if they think that people are trying to give them things that they don't need. I think we need more funding from philanthropy for Black health and medical community organizing and activism, right? I think we need to develop tools to change the clinical environment and patient-provider relationships, or you could just start your own for us, by us. We actually also need to fight like the sort of online fake news, right, that we see happen so much through social media, right? That a lot of false information gets spread, including in healthcare, around healthcare issues through those venues. And there's no legal sort of restraints on those platforms to actually provide accurate information and ban channels of disinformation. And then lastly, one of the things I've been, working in public health for, 20 years, and I did not know until COVID-19 that the CDC had the authority to do something like stop evictions nationally, right, in a public health emergency. And I'm like, more of that, CDC. Let's do more of that. And in fact, let's give CDC and other public health authorities potentially more authority to do more things like that, right? We certainly know, through this conference, a lot of stuff about sort of prisons, jails, criminal justice systems comes up. Primary places through which like infectious disease sort of mini epidemics happen, not because people in prison are any dirtier than anybody else, but because those institutions don't invest, in medical providers, doctors. The food is terrible, a range of things that actually create infectious disease to spread in those institutions. And what if the health departments actually had authority to shut down prisons and jails when the conditions were that terrible, right? Like these are the kind of things that I'm interested in thinking about. So with that, I will stop. Thank you very much.
Wow, this has been just so inspiring already. So I'm really pleased to be here. I am. As Mark said in my introduction, I'm a professor of law here at the university, and I also am a lawyer and a litigator, and I have been involved for the past 2 decades in litigation work challenging restrictions on abortion rights in Ohio, and particularly most recently on laws that actually ban abortion and prevent people from making the decision for themselves about whether to terminate a pregnancy. So what I want to do with my comments, and to kind of connect up, I think, to the presentations that just went before me, is to talk about the law and the role of the law in all of this picture around reproductive health care and its connection to social justice, and what the law kind of has done, hasn't done, could do in the future. So I'm going to start with reproductive rights, because that's the framework that the law and constitutional law uses to talk about abortion rights. Well, it mostly tends to be another way of saying abortion rights, but to talk about people's abilities to make decisions about their bodies and reproduction. So, not to belabor this, we all know that the Supreme Court decided in 1973 in Roe v. Wade that there was a right of an individual to make the decision whether or not to terminate a pregnancy, that's found in the 14th Amendment of the U.S. Constitution, and that the groundwork for that had been laid by earlier cases. Roe v. Wade was actually subsequently modified by a case called Planned Parenthood v. Casey, which upheld various kinds of restrictions that states could place on the person's abortion decision. So saying that the state had the power to limit that decision in various ways. The only kind of law it struck down was a law requiring spouses to be notified of the abortion decision. And then, of course, the Dobbs decision that came, that I'll speak about in a moment, that came this past summer. But I think that the framework for reproductive rights was, created by these two cases, Roe and Casey, and I just want to point out a couple of things about it that sort of play into our legal understanding of what reproductive rights mean. One is that they are understood as being what's called a negative constitutional right, which means that the understanding under the U.S. Constitution has always been that you have a right to have the government stay out of your business. So, for example, in terms of your decision whether or not to have an abortion, that the government can't stop you from making that decision. But that also, the flip side of that is that the government also doesn't owe you anything according to the Constitution. It doesn't have to make sure that you can actually exercise that choice. It doesn't have to provide you the means to exercise that choice if you can't exercise it, right? It's also an understanding, as I kind of alluded to, that's really particularly focused on abortion to the exclusion of other kinds of reproductive health care that people need, the bigger picture of reproductive health. And it's an understanding of reproduction and decisions about people's, parenting and pregnancy that really focuses on what choice, what individual decision someone is making at a particular moment in time. And is the government stopping you from deciding at the moment that you have an unplanned pregnancy and you walk into that clinic, is the government going to allow you or stop you from having an abortion if you want one, right? But we all know, that these kinds of decisions are not individual, moments in time that happen in some kind of vacuum, that people's, decisions around pregnancy, that their reproductive lives are formed by a bunch of circumstances, some of which are chosen, some of which are not chosen in your life, right? That the moments of choice might go back to whether or not the person was really choosing to have sex without protection, choosing, their life circumstances that have led them to where they may or may not be seeking an abortion. So it's the understanding that comes from these cases is a much narrower sort of, impoverished kind of understanding of what reproductive autonomy, reproductive choice really means. Okay, so, and then we come to this past summer when even that choice, even that right has since been taken away by the Supreme Court, which in the Dobbs decision, said actually there is no right to make your own decisions about a pregnancy under the U.S. Constitution because there's no, history or tradition of protecting that right, essentially, going back to sort of the 17th century and even earlier. Okay. So where does that leave Ohio after Roe v. Wade? Well, what happened, and just very briefly legally, is that we had a law that went into effect that banned abortion after about 6 weeks of pregnancy, so very early in pregnancy with very limited exceptions, made it even harder for people to exercise their rights in Ohio because there's a 24-hour waiting period. You have to go for one visit to see the doctor, give informed consent, get an ultrasound, come back 24 hours later for the procedure. So making it very difficult for people to access care within that time period. This law has since been put on hold by the courts in Ohio, so it's not in effect. And Ohio is back to the status quo with respect to abortion rights. But I also want to note something about this law that's very typical of laws across the country, which is that restricting abortion, which is that they don't criminalize the pregnant person themselves in terms of if someone were to get an abortion that violated the law, the doctor could be prosecuted, but the patient normally cannot. However, I'll come back to that point in a minute, that doesn't and has not prevented criminalization of pregnant people for pregnancy outcomes. Even, before the Dobbs decision of this last summer, after, it will continue to happen. So the state finds other ways to criminalize pregnancy, people who have, pregnancy outcomes that the state either thinks are suspicious, or when people try to end their own pregnancies, things like that. There are all kinds of laws that can be used if you really want to go after someone in this circumstance, including, laws like trying to interpret child abuse laws to apply to these situations. There have been cases involving, treatment of a corpse. There's a law around that. So things like this. Okay, so criminalization always has been and remains sort of part of this a story, whether or not we have a constitutional right to end a pregnancy. Okay, but I kind of want to shift then from that legal framework of reproductive rights to thinking about something called reproductive justice, which is a little bit different and a little bit of a broader concept. Here's Gloria Steinem talking about reproductive justice, although Gloria Steinem did not start the reproductive justice movement, as I'll talk about in a moment. We might think about as a way into reproductive justice and why a broader framework than the reproductive rights framework is needed. We might think about, for example, the Hyde Amendment, which is a federal law, or actually it's an appropriations rider that gets passed every year, actually, since the 1970s, that says that Medicaid will pay for people to have children, but will not pay for abortions, except in super limited circumstances like rape, incest, or life-threatening pregnancies. So this is an example of something that the Supreme Court has actually upheld as being, even during the Roe era, perfectly consistent in the Supreme Court's view with the idea that you have a right to terminate a pregnancy, because it goes along with this negative rights idea that the government doesn't have to help you exercise your choice. And Henry Hyde, who was the first person to create this rule, this appropriations rider, was very frank about what he was trying to do. He basically said, the quote is here, "I certainly would like to prevent, if I legally could, anybody having an abortion, a rich woman, a middle-class woman, or a poor woman. Unfortunately, the only vehicle available is a Medicaid bill," right? So I can only affect the most vulnerable, the people who are dependent on public benefits. So that's what I'm going to do, right? So that's obviously, again, kind of as another way of pointing to the shortcomings of this framework. So where does reproductive justice come in? Well, the reproductive justice movement was actually founded by Black women in 1994 who came together in Chicago in advance of an international conference on population and development to argue for seeing reproductive health care in a broader framework of much needed access to health care for everyone, for Black women, for LGBT people, for all people, that the government had a duty and a role in supporting people's access and supporting people's choice, and that this went beyond this sort of narrow understanding of reproductive rights that we have. And this was a full-page ad. They put out a full-page ad as a result of this this conversation that was published in 1994 in a paper, The Washington Post and Roll Call. Okay, oops. So what is reproductive justice? There's a very lengthy description here, but the short version here is that it implies or that it means basically a right to choose to have children, not to have children, and to parent the children we have in safe and healthy environments. That's what is, that's the essence of true reproductive autonomy. So going from the idea of legal access to true choice for people. And this, of course, has to entail that healthcare, reproductive healthcare, sexual healthcare is safe, accessible, and affordable. So what are some reproductive justice issues? I mean, the things we've been talking about today, right? There's all kinds of healthcare issues that touch on reproductive justice. So it goes, well beyond just access to abortion care. Again, I couldn't talk about infant mortality better than Dana spoke about it today. But obviously, we've talked about the disparities in terms of infant mortality, maternal mortality. We could also think about, here are a couple of billboards that present, I think, two sides of this question, right? These are, again, around, the first one is an anti-abortion billboard that describes Black children as a, quote, endangered species. And then the second one, which is from a group that targets women who are addicted to drugs, who offering to pay them money to get birth control. So I think, like, from a reproductive justice standpoint, you might look at this and say, how about instead of constantly trying to control people's reproductive choices, right? Like, one is a have babies, the other is don't have babies billboards, right? But there's this constant attempt, and obviously targeting Black women in particular, to control their reproductive decisions. So how about an idea of reproductive justice that would just say people should be empowered to make their own decisions, whichever they are. And also, again, this idea that even freedom from violence is a reproductive justice issue. I mean, if you can't raise your kids and keep them safe, then you're not being given the opportunity to parent in the way you choose. So I feel like I just want to say just a couple of words here about the fact that we're now in this moment, this post Roe v. Wade, where there's no right to federal constitutional right to access abortion. Maybe we're in a moment where this entire movement can be taking a beat and saying, what do we build from here? The sort of small, somewhat narrow, impoverished view of reproductive autonomy that had been built on Roe v. Wade, even that is gone now. So are we in a moment when we can imagine a new world of reproductive justice, and I'm speaking specifically from the legal perspective, right? Is there some way that the law can help rebuild a world with reproductive justice? And what would that look like? And honestly, I don't know. I'd love to hear your thoughts. I think, there's a lot that could be said about this. I mean, I think one piece of it has got to be an idea of decriminalization, right? And connecting decriminalization of pregnancy outcomes, right? People who have bad pregnancy outcomes or people who end their own pregnancies, to the broader movement of decriminalization, right? It's all interrelated. The same people who are targeted for their pregnancy outcomes are the same people who are targeted by the criminal justice system in all kinds of contexts, right? And it's time for the reproductive rights movement to reach, to connect more broadly to decriminalization movement. Also, I think, it's time to think about demedicalization, right? So there's a lot of power in the medical establishment, and reproductive rights legally has really centered medical professionals in a lot of different ways as sort of the gatekeepers of care, as the experts around healthcare. And of course, we need medical professionals, but also a lot of reproductive healthcare are things that medical professionals aren't needed to do, right? That people who don't have formal medical training can do. This has been the history for centuries, that people help each other deliver pregnancies, terminate pregnancies, help them through pregnancies, right? And so that maybe a legal model that doesn't rely so heavily on medical professionals as centering the right around those medical professionals might be another direction. So basically, thinking about new legal theories that could be grounded in a concept of reproductive justice, and that would not be so narrowly focused on individual choice, negative rights, and abortion rights alone is where I think the movement needs to go. And so I will stop that right now. Thank you.
Thank you so much to each of you, to Dana, Kenyon and to Jesse for really spelling out some ideas about what liberation and community health looks like. So we have a microphone over here. We have about 20 minutes for questions, and I would love to have some folks who haven't had a chance to take the microphone to speak first. And I would like to encourage our students to take a chance at the microphone. So Councilman Martin will be sure to yield if anyone wants to go that hasn't had a chance to speak yet. Right, Nathaniel?
I just got one question I wanted to ask the young lady.
Okay.
Where she's located at, and I'm through.
Okay. So I think that's for you.
Yeah.
Able to start.
Oh, okay. So I am located. First of all, let me say this. I want to thank you because I saw Gloria Steinem up on the screen being quoted for reproductive justice. And I instantly was like, oh, I can't wait to pull her aside after this. It was all over my face. My executive assistant has texted me like, fix your face. So I just want to thank you so much for then correcting that and showing that reproductive justice was a Black woman's issue.
Yep.
And that it came to the forefront from Black women. We very seldomly or never get credit for what we do in society.
Yep.
And so that's why when I saw Gloria Steinem, I'm like, oh God, I can't wait to get her after this. But yes, so we never get credit. So when we don't get credit, it just bothers me to no extent because we do so much in this society as Black women, and we bring so much to the forefront as a community, not just Black women, but Black men, and we never get credit for it. So thank you so much. To answer your question very simply, we are located in Euclid, Ohio on Lakeshore Boulevard. I'm in the plaza with everybody. Most people know Kim's Wings, but Aldi's, Dunkin' Donuts, things like that. We are currently in the process of having conversations about what expansion looks like to include, in our first place that we'd love to be is the city of Cleveland, to provide primary care and pediatrics with the same focus of Black providers care.
How do we reach you? What's your phone number?
216-815-4325.
Yep.
And I'll make sure I give you a card before I leave.
Yeah.
Okay.
My name is, my last name is Edwards. I'm too old for y'all to call me by my first name, okay? So, this is my story. I was born and raised here in Cleveland. I just recently permanently moved back here from having lived in Seattle for like 42 years. But my migration back home started in 2012. So now I'm here permanently. And my career was in Seattle. I worked as a nurse in Seattle. So I'm well ingrained in that healthcare system there. When I came home, I said, the healthcare system has not changed. In Seattle, they're more preventive. Here, they're innovative. And so I'm in the healthcare system here now, and I'm feeling those same alms that everybody else is feeling. You know what I'm saying? I'm not being funny. Twice I had major complications. Forgive me, I ran my butt back to Seattle, where I knew I could get adequate health care, and I shouldn't have to have done that. You know what I'm saying? So this young lady sitting on the stage, I want to say, baby, what can I do to help you? Okay, I might be retired, but I still got a little bit I could.
Thank you so much. There's so much, right? We look for volunteers all the time.
Okay.
Word of mouth, we're still trying to get our brand recognition out.
Okay.
So word of mouth, because I think a lot of people know a little bit about us, but not quite enough.
Okay.
Like they'll come up and say, oh, I saw, you guys on the news, or I saw you in the newspaper. However, they just still don't know what we do. So definitely any word of mouth definitely helps. But I do want to talk about you saying, there's these 3 hospital systems and they haven't changed. And the reason is because they don't have to. Especially in our community in Cleveland, we are a generational hospital system in Cleveland. So that means wherever my great grandmama went to, my grandmama went to, my mama, my sisters, I'm going to that same hospital system. And a prime example of that is my family. And I always use my family as an example because we the first ones to do it. We are traditional about one specific hospital system in Cleveland. And my mother recently had surgery at that hospital system, and it was the worst care. She had to beg to go to the bathroom. She had to wait an hour to even for somebody to take them, and they still didn't do it until I had to act very ugly in the hallway to get somebody to come and take her to the restroom. She had to beg for pain medicine, and then there was another older black woman screaming out, if I was white, y'all wouldn't treat me like this. I guarantee you my mother going back to that hospital system for any other care she needs, even though, right? And it's just because we have a generational commitment to the hospital systems. And so if we continue to do that, why would they change?
Right.
We're going to keep taking them our money. We're going to keep giving them our insurances.
Right.
And so what we have to recognize is you don't have to be a part of the hospital systems to get care. Going through Village of Healing, it's a community organization, but now I'm out of the hospital and I can advocate for you way more. So now when our patients hit the door of those hospital systems, they see Village of Healing on the top, and my staff can tell you, no matter what happens, they call us first. Was everything okay? Did your patient complain about anything? Did they say anything? They had an issue with one of my patients on labor and delivery. Called me at 7 a.m. in the morning. Can you call this patient? Can you have a conversation? But if I was still a part of that hospital system, my patients wouldn't get that at all. Okay. So I think we as a city and as a county have to start holding these systems accountable, and that means pulling out our money. Because our money is what talks. So if they don't ever have to change because we still giving them our money, why would they? Right. And so that's where we got to start first.
Okay. Thank you.
Hi, everybody. I believe my question may be for Ms. Dana and Mr. Kenyon, and whoever else can answer. I don't know if I have a question, but I do. I possibly suffer from endometriosis, and my 21-year-old niece also suffers from what they have tried to diagnose her as endometriosis, and also my 19-year-old little cousin has. And the only thing that they can give us to rectify that is birth control. And there's a myth, there's a theory out there that, oh, you're just trying to sterilize black women so that we don't have kids, and this is the only way that this can be fixed. I'm afraid for my 14-year-old daughter to have a cycle that is painful to her, that they will give my 14-year-old kid birth control. You know, I don't want her to have that, but I want her to be able to make the decision to have birth control on her own, to not want to be a parent too early. That is the only reason that I want her to be able to take birth control. So there is a theory that y'all trying to sterilize black women with this birth control. So there, Mr. Kenyon, that. And also, what else can be done? And in all honesty, I feel better with the birth control. And they told me to just basically stop having a period. Is that even healthy? I don't know, but I feel better taking it. But this shouldn't have to be a lifelong cycle until I have menopause and I no longer have a cycle. And then is there a corrective way without birth control that I can gear my daughter towards so that she doesn't have to be, or my 21-year-old niece, that if she takes this birth control forever, does she never be able to have a child of some sort? So the theories that black people, we don't want to take no medicine, I'm big on. I don't want to take medicine. I don't like medicine. I'm not vaccinated, if you would say. And then there's another thing. I had to fire my internal medicine doctor from being my internal medicine doctor because she told me that I was making the wrong choice about not being vaccinated, and that my wanting to take a holistic approach was the wrong decision. And I told her, and the way she talked to me as if I was uneducated and I didn't know what I was. And I told her, I said, it's black women who are so underrepresented in the hospital, and that you feel that this privilege that you can just say whatever you want to say to me and tell me what I'm supposed to do versus trying to listen to me, understand me. I had to go above her whoever her manager was, just to get her removed off of my hospital records that I never ever want to be associated with. To this point, I don't even have a reason to go back into Metro Health anymore. But I would rather have a black woman seeing about my insides versus or my my health as a whole, and to have let me start the generation of, you know what, we don't have to go into these hospitals.
Okay.
It can be something else. So I appreciate you, Ms. Langford, of having that availability to black women. My mother gave me a list of 4 black women, like here go 4 of them right here, you know, mental health, women's health, and it's so that, yes, we get called racist, we get called prejudiced because we don't want to go into the hospitals and see other people that don't look like us. But at the same time, when I do, all you do is keep giving me medicine. And I'm telling you, I'm not comfortable with medicine because of the theories, because of the Tuskegee Institute, and maybe not going with that far, but to the point where I've never really felt healed. I just feel a little bit better.
Thank you. So let's let our panelists.
I'm gonna defer to you on the medicine part.
Well, see, that's the part I'm not, because I'm not a doctor, so I'm not gonna. I won't make any recommendations around medication. But what I will say is this: well, so one, on the endometriosis in general, part of what I'm also advocating for is that you know, Black people have to be also in those rooms where kind of decisions around science and research are happening, because to me there's a question then, because to me part of what the underlying piece is that we need to be doing more research on endometriosis to figure out what are some potential other options. First of all, I think even the sort of source of it, because that's not my expertise, but from what I understand, it's just we still don't even understand fully you know, why and what happens to women who have endometriosis other than the racial disparities. So I think so one is that, and I get, you know, your ranges of hesitation around kind of science and medicine and healthcare, whatever, but if Black people aren't in those rooms where decisions around research are happening, then those kind of problems never get solved, right? Or never, et cetera. So to me, that's why it's been important for me to kind of be a research activist, right, in terms of, you know, engaging at, you know, both here in the city, the county, but also at CDC, FDA, you know, NIH. Like I know Tony Fauci, knows who I am. I engage at that level with folks. So. Because I think that we have to still be in those spaces to make sure those decisions are made around, you know, where resources go in terms of research to help folks in different conditions that otherwise wouldn't be studied.
I think to answer about your personal health care, I'm gonna make sure you get a flyer, because that's gonna be a conversation that you need to have one-on-one. As far as your daughter is concerned, you know, because I don't know everything, so I can't sit up here and give you advice, because then she might take my advice like what a lady on stage said. So that's what I'm gonna do too, and it's very personalized. Yep. And it's very personalized. So I'm gonna encourage you to make an appointment, and we could definitely have a conversation about it. But I think that's the key point, is that a lot of times when we go into these healthcare systems, they're slotted 15 minutes to see us, 30 minutes to see us, and they're hurried and trying to get to the next, right? Because there's something called RVUs, and they have to meet something in order to bring those dollars in, right? And so that was one of the reasons that we started as a nonprofit. And so it's still difficult for me to bring in money so I don't have to meet as much those RVUs, and I get to use the point, but I'm having conversations and I'm working with patients and I'm doing all that, so I don't have to meet those RVUs as much. But then even in philanthropy, they want to know, well, you can bill, so why you keep coming to us for money? Because you can bill. But so that means that now you're saying, and I can't give the same amount of care I wanted to give because I'm focused on trying to go from room to room, and that's what's happening in these systems. What I'm going to tell you is, as far as medications are concerned, as far as all of those things, is informed consent. And that's my biggest thing with my patients. I have to respect your decision, but that also means that I'm gonna challenge you, and I need you to be able to challenge me back so that you have informed consent. An informed consent means you did the research yourself, you've read it yourself, and you've come to a decision. And I can't do nothing but respect that. What I don't like, and I always tell my patients is, don't come tell me what Facebook told you.
Right.
Don't come tell me what Instagram or TikTok told you. Mm-hmm. I need you to sit down and really read the information for yourself. And whatever you don't understand, from real resources. I celebrate you for even discussing Dr. Sebi, because people don't even want to talk about that, right? So I need you to make sure that these are credible resources, and let's have a conversation. And if you still come to that decision that you feel like this medication is doing this, I can't do nothing but respect it and offer you another option. And that's what I'm supposed to do. That's a part of my job.
If I could add one piece to that, because you sparked the thought in my head. So I also think part of it, so we understand that like the just whiteness and then the white supremacy, sometimes no matter who the actual people are in those systems, function the way that they do, right? So that is true. At the same time, I also tell folks, so like in 2021, I did a bunch of like, and actually for some community-based organizations here in Cleveland who didn't even know me, didn't know I had moved back to Cleveland, but somehow found me on the internet and were like, hey, we heard you can tell us about these COVID-19 vaccines, because we or even some of the staff didn't want to take them. And so what I explain to folks is white people don't own science. They don't, right? The whole kind of concept of inoculation came from an enslaved man in Massachusetts, right? So this happened right in the 18th century. He was a slave to a physician, and it was a smallpox outbreak, and none of the black people were getting sick, and they didn't understand it. They thought it was witchcraft. And in talking to this man who was enslaved, found out that actually the Africans already knew how you sort of inoculate against disease, and so they were doing that for themselves, right? So the technology of that is our birthright, right? Mm-hmm. And so so to me, like, you can make whatever decision about vaccination, whatever, but black people, we do this too. And even the Moderna vaccine, Dr. Kizzmekia Corbett, right? Dr. Kizzy, who I know, black woman helped develop that vaccine. So part of me also sometimes is like, I get the racism in the system. What I tell people is sometimes the things that you see on the internet, that ain't it. There's racism in it, and I'll point you to where it is, right? But sometimes what we often kind of get sort of fed is not where it is. And so, and also that there are black people at every level at this point in kind of science and research who are sitting at these tables and helping make some of these decisions, and even pushing back against certain decisions. I am sometimes in that role myself. So just to say that too, you know.
Let's go here, and then I'll come to Miss Rita. So, yeah, but she's had many chances. You haven't had a chance to speak yet. Sorry, Miss Rita.
I appreciate that. Thank you. Thank you all for your talks, and this is for any panelist up there. But I think something that is kind of getting out, but I want to tease out more broadly, right, is that there's a large capitalist class interest in the reason that these things are a problem. And so if you could speak to, and I think some of your presentations did, but a little bit more to the importance of universalizing and decommodifying healthcare to all of the work that each of you do. Thank you.
Yeah, okay. And just so we know, we have about 4 minutes, so I think Miss Rita will be the last question. So, but no, stay there.
Yeah, absolutely. I mean, 100%. I'm glad you said it. I mean, I think that at least, like, again, from my lane is legal, right? It's the law, and it's but from a reproductive justice perspective, you cannot have reproductive justice unless you have universal access to healthcare. I mean, there's no way people are actually making their own decisions, right? Are free to decide if, when, and how to parent, to make important reproductive decisions without the ability to, afford that equally. I mean, it's never made any sense. That's never like, what definition of choice is that? If it just means, you can only get the healthcare you can afford. So 100%.
Medicare for all me, yes, for that very reason.
Dana, do you want
I think I'm a huge proponent. We talked about demedicalizing, certain procedures. I was a huge fan when Plan B came out, that you could buy it over the counter. And then I think COVID has exposed the healthcare system that we don't need it as much, in that telehealth became a huge thing, right? So you didn't even have to leave your home now for appointments. And now even when I make an appointment, I'm like, I don't have time to come in here. You got telehealth available? So it's exposing the healthcare system to say that we need to change it, right? And we need to change it with the times. And so that's definitely a conversation that I think sparked from COVID-19.
Can I just jump in with one more thought I just had too? Was I think you were the one that was saying about like the CDC's. Oh yeah, the CDC's power, to stop evictions and stuff like that. I mean, I think that also has to go hand in hand with a broader understanding of what healthcare is. Like like writing prescriptions for housing. Writing prescriptions for things that we don't normally think of as healthcare. It's all part of what makes people healthy and people able to thrive. And I think that that should be a piece of it too.
Well, and we actually see it, right? Like I get a lot of notices from patients that are asking me to stop their lights from being cut off or their gas from being cut off. And so I remember being in healthcare systems where NPs and physicians were like, I'm not writing that for her. She needs to do this and she needs to do that. And you could walk in my office with that sheet and I don't ask you no questions, right? Because if I got the ability, because having your lights on and having your gas on, that is a healthcare issue. Yes, I don't care who you are. So if you come in with that paper, I'm not asking you no questions. I'm going to sign that and let's go. And so I think, that just goes back to what you said.
As you heard, the name is Rita. But I've been working with the medical department at Case Western Reserve, the School of Medicine. And this was in regards to the community health situation and the training of doctors in regards to health care for minorities, color, and everybody in actuality, but especially for people of color, because a lot of that information has not been heard or was dealt with in regards to trauma and racism being a major part of causing a lot of the health proponents of Black people and people of color. But the one thing I do know is advocacy. Many people, especially Black people, because they all think that the doctors know everything, and their word is law or God, whatever. You have the right to say, I won't take this, I'm going someplace else, which is what I learned when I found out I had a kidney disease. Now, I'm a very healthy person. I was partially vegetarian, not a big meat eater, and other things that go with it. Saved myself through the whole medical thing of dialysis, in which I maintained my energy level because of the way I ate and the way that I helped them create the database for foods that you can eat, so you know that your 2,000 milligrams of potassium, phosphorus, and the other things regarding to kidney problems can help you live a better life. Unfortunately, people that already have diabetes and high blood pressure, it's a problem. But the one thing I found out while doing this, I learned more about myself and more about the medical situation. And I found out that the platforms that are used to create doctors is a special template, and it was only the template that followed how you treat white people and how you don't treat Black people. I had an African doctor who would not check my records to find out that I had a kidney disease because my blood pressure went up. The statement told to me was, well, you're Black, and the food that you eat and where you live and all of that has a lot to do with your blood pressure going up. Just take these pills and you'll be fine. I threw the prescription in the garbage and continued to do my health in regards to eating right, living right, and curtailing my stress level. My kidney problems didn't rise to the surface, so to speak, until 30 years later, because there is no warning except for my high blood pressure. If that doctor would have checked my history of high blood pressure, it would have found that it was caused by me having a kidney disease. So I learned about advocacy. I am the one that dictates what you do to me. If you can ask any of my doctors, and the primarily one that helped me through this, he tells his students, listen to what she says because she knows her body. Because my first words to him was, if you don't give me the truth, University Hospital will be called the Rita Knight Gray University Hospital. I found that that is what you have to do. Advocacy and learning about your body and understanding what's going on. So when you do say it's good to have black faces, that is good, but you also have to investigate them because a lot of them have been raised in that template. And it's the wrong template.
Mm-hmm. Thank you.
So in response to that, I will say this. I had a gentleman from Sisters of Charity, when we went to them for funding, ask me, when you say black, do you mean culture or do you mean skin? And for me, it was the first time I had been asked it, and I actually had to think about it. And I responded to him saying, I do mean culture, right? We all know the term all skin folk and kinfolk. And so you, no matter what in healthcare, period, you should, like you said, be investigating, listening, and advocating for yourself, right? I think that by me pulling away from the system, there's a couple different things I was able to do. When I interview and when I interact with someone, I'm able to use discernment, right? So even with my providers, when they walk into our space, I'm able to watch how they act, because when they're coming into my space, they're coming into a very much unapologetically black space. From my staff to, like I said, to the artwork, to the aesthetics of the entire clinic, and I'm able to use that. A lot of times in healthcare systems, they're looking to fill faces, right? They want to be able to say, we have diversity, equity, and inclusion here. And so they're not using that same discernment and hirement, and they're looking to say, oh, look at us, 10% of our doctors are black. And so, yes, of course, you should always be using that. But let me also say this. When we are educating people in medical school and nurse practitioners as well, we have to recognize that we have to be looking at the fact that racial disparities are here. And racial disparities are happening, and how do we educate in accordance to that, right? 3 to 5% of the physicians in this country are black. 3 to 5% of MPs in this country are black. 8 to 12% of the midwives of this country are black. So what does that mean? The chances that I walk in and get a black provider are still going to be very slim, right? And so how do we go about educating the white, and every other culture in medical school? And that the first thing that I'm going to root for is anti-racism training. Mm-hmm. Not bias training, we need anti-racism training, and it has to start in those schools. Because by the time you get to the medical clinics and to the hospitals, you're now interacting with attendings that already have that racist thought in their mind that you as a black woman ain't gonna feel pain the same way that she does from Pepper Pike.
Yeah.
And so it's too late then. And so if we get them in the schools, that's where it starts. And then we got to start holding these hospitals accountable for their education as well. Again, no bias training, anti-racism training. And then what are the outcomes? And let's hold you accountable for those outcomes once they come out. There are laws in place, y'all, where they don't have to put out how many black women die in these hospital systems, and it protects those doctors. Whereas if we knew that, if I knew that this one particular hospital has a higher rate of black women dying, you think I'm gonna go to that hospital for care? But that's what we have to do. We have to start holding hospitals accountable, again, with our money, right? And again, with the trainings that they get.
No, you're exactly right. And when I said I was working with the Case Medical School, that was to create a type of template tool in the teaching of. And this was the first, shall I say, the first time that there were almost half and half, black people of color, Latins, and white people together creating this tool where racism and stress were the primaries in regards to understanding how to treat, what the problem is, how you investigate and research. And I think the template is halfway finished. It's also interactive, so it can be used in schools. And that's one of the things that was amazing to me when I was asked to participate, because I had never been asked. And I'm quite sure a lot of other people of color have never been asked to put forth. And we put forth that training, putting it into the training regarding racism, regarding the whole thing of stress, because stress in regards to black people is very different than it is to white people.
Okay, thank you, Ms. Rita. Let's give Kenyon and Jesse the last word here.
Yes, I am with you on the advocacy piece. You know, I spent the summer, the organization I work for, Prep for All, we, did a lot of work at the federal level when, monkeypox was beginning to happen and the federal government was sitting around with millions of vaccines that they just weren't moving and whatever else. And so while I was able to push initially and help get that sort of moving federally, then the Ohio Health Department wasn't doing anything. And so, I wrote 2 pieces in the Ohio Capital Journal that helped get some of the kind of ball rolling here. But I remember after the second piece I wrote, the Ohio Health Department, they didn't send me an email saying, oh, we read your pieces and we know you're pissed, whatever. They just sent me a calendar invite to a meeting. And I was like, what? And so, but I'm like, but I'm going, right? Okay. So I get on the Zoom meeting and it's 2 people from the health department, the state health department, and then the county, Cuyahoga County, the city of Cleveland health department, and then some of the community-based organizations. And the state health department was like, oh, well, you know how, conservative Mike DeWine and the state legislature is. And so basically what they said in so many words, we can't do anything. So we're going to need the community-based organization. And I'm going to stop you right now. No, you're not funding these organizations to do this work. You don't even have a damn landing page on the state website about monkeypox, about what the symptoms look like, where people can get tested if they want it. And I know, because I do federal work, I know how many vaccines y'all sitting on, 4,200 vaccines that you ain't even fucking move, excuse my language. So you tell me what you're going to do, right? Yeah. And that changed the conversation. And unfortunately, I don't know, maybe it was my 20 years in New York. I can talk like that to people and it is what it is. But there wasn't, I was the only person that mad on the call enough to get that sort of moving. And then I had to do a bunch of work with individuals here who had monkeypox calling me. They were trying to get tested in the city and they couldn't know every hospital they called. Nobody knew what to do. And so then I had to yell at Cleveland University, Metro, all of them got it, right? Until there was an infrastructure. And it's unfortunate that we have to spend so much time doing that kind of work for what should be basic strategy, but so there's the self-advocacy piece, but then there's also just advocating at the systemic level, so that because I am who I am, I'm able to, in fact, I know somebody at Metro, my doctor's at Metro, and when I called her and said, what are y'all doing on monkeypox? Nobody seems to be able to get tested. And so she called people, and I found out later that she told him, she's like, he's a big deal. Don't piss him off. And cool, I'm glad I'm able to use that, my reputation that way, but it shouldn't come to that, because somebody who doesn't know me, you shouldn't have to know me in order to get treated well in the damn hospital system.
Yeah. Thank you. Okay, thank you. So this is an amazing panel. We learned the 3 themes of our think tank: respect, speaking truth to power, as you just demonstrated, Kenya, the renew, and the reimagine. So let's thank them. They're just fantastic. So.